Hi everyone, Shannon here and Karen. We are actually going to be discussing question 3 today. What I'm going to do is read the question to you. You'll see it below. You'll have 4 options for the answers, and I would suggest pausing the video so you can choose which you feel is the right answer, and then resume the recording so Karen can also discuss with you why the answer is correct, and then we're also going to discuss why the other ones aren't correct. So you ready, Karen?
I'm ready.
Okay, perfect. So question number 3 says, goals in the treatment of a patient admitted with hypertrophic cardiomyopathy, HCM, are to, you have the 4 options there. So I'd pause now and take a look at all 4 of those and pick what you want. And then now we're going to have Karen discuss what the correct answer is and why. So Karen, what's the answer to this?
Okay, so the correct answer to this is actually C.
Okay.
The 3 main goals in hypertrophic cardiomyopathy are to maintain adequate preload, avoid medications that increase contractility, and control any kind of arrhythmias that the patient might be having.
Okay.
So let's just talk a little bit about hypertrophic cardiomyopathy, and then we'll just touch again on dilated, just so people remember the difference again. Okay. So hypertropic's the least common of the 2 types of cardiomyopathy. And so when I like to think about it, I like to think of the heart, particularly the ventricle, as shaped like a football. Okay. So, and the reason what happens with hypertrophic cardiomyopathy is you have a very thick muscle wall, but a very small chamber.
Okay.
So there's not a lot of space for blood, but you have this really thick muscle. And so one of the things you don't want to do is add like an inotrope, like a dopamine or something like that, because what that's going to do is really cause that muscle to even contract more. It's already a stiff myocardium, so you don't want that. So nothing to increase contractility on these patients. So you don't use DIG or things like that. And then they have this really small chamber, big muscle, small chamber, so there's not a lot of space for blood. So we don't want to dry them out. If you drop their preload, then they get into trouble really, really quickly. Okay. Another thing that happens with the cardiomyopathy patient is they have trouble getting the blood out through the aorta during contraction. And it's because they kind of overgrow their septum a little bit. Mm-hmm. And when the septum gets overgrown, it's hard for the blood to get past that. There's actually a surgery where they cut down the size of the septum. I know, it's kind of different. So, and then they also have a lot of arrhythmias. One of the things, generally, they may not add like a medication necessarily, but they might end up with an ICD, something like that to control an arrhythmia if they were to have it. They could use medications, but a lot of times they'll give the patient an ICD. So the best answer, once again, is to maintain adequate preload. Don't dry these people out too much. Mm-hmm. Avoid medications that increase contractility, and then control any kind of arrhythmias that might be life-threatening to them.
Okay. So, and then just to recap again, when you say these ones, we don't want to increase the contractility in these types of patients, it's because the heart is already, it already has a large muscle, and forcing it to contract more isn't going to do anything good for it.
Correct. That's exactly.
Okay. And then we want to maintain the adequate preload, because if they have a small ventricle, even a large muscle, there's not a lot of space there. So if we got rid of the small volume that they already had, we'd actually be like probably dropping their blood pressure then. Is that correct?
Exactly right. You end up dropping their blood pressure.
Okay, awesome. And then if when you say an AICD, is this only because the arrhythmia that we're concerned with is if they went into like a VTAC or VFib? So if the other arrhythmias aren't causing them problems, do we have to do anything about those?
Generally, they're going to just look for more life-threatening arrhythmias. Okay. Things that are causing, significant problems for the patient. But even like an atrial fib could be really hard on a patient like this. Mm-hmm. Because that would drop their preload. So that might be an arrhythmia they would want to try to control with an ablation or something like that.
Okay, awesome. Well, that makes a lot of sense. Well, thank you so much, Karen. And thank you for discussing
Oh,
the hypertrophic cardiomyopathy.
do you want to talk about, just recap again on the dilated, just to remind people the difference?
Actually, I think that's good because I think being able to compare the two would probably help set it in their mind. So we talked about HCM, so now we're going to talk about the dilated cardiomyopathy. So is this technically the opposite of the hypertrophic cardiomyopathy then?
Well, I don't know if it would be exactly the opposite, but it is another cardiomyopathy. And when I think about dilated cardiomyopathy, I think about the basketball.
Okay.
And the basketball is this big chamber, but it's not a very good pump. It's floppy and it doesn't pump really well. There's a lot of blood inside there, but it's really hard to get it to contract well. Also, they sometimes have mitral valve problems too. The mitral valve gets kind of pulled out with this big ventricle. And so what I like to remind nurses, just so if they can't think of exactly how to treat these patients, generally speaking, we treat them like heart failure patients.
Okay. So
And yes, go ahead, Shannon. How do we treat
so let's see. So a heart failure patient, we would want to decrease the preload and afterload.
Exactly. Decrease preload, decrease afterload. And what else could we do in a patient that needs more
Contraction. So we want to increase contractility for them.
Exactly.
So,
Perfect.
all right, awesome. Well, thanks so much, Karen. If any of you have any questions about what we just discussed, please leave comments below or send us an email, and we'll see you next time with our next question. All right, thanks, Karen.
Bye.
Bye.